Hello, everybody. I am Krista Reimel coming to you today from the Point Retreats. I am a registered nurse, a former healthcare administrator, and currently the co-owner and founder of the Point Retreats. I have the privilege of coming to you today with Dr. Pete Melchert. He is going to introduce himself in just a moment. But I want to share with you why we're doing these series of interviews with primarily local or kind of near and dear healthcare workers from the front lines. And that's really to give you accurate information coming from individuals who are seeing what's happening firsthand with COVID-19. Our goal is really to try and come together as a community of healthcare providers to provide solid, good information, but taking out some of the fear factor that we're all sensing in some of the mass media today. And we also really have the goal of trying to provide a level of hope in a time where I know it's really needed. So I'm very grateful for all my colleagues who've taken time to be with us over these series of interviews. Because I'm interviewing clinicians, I do want to put a couple of medical disclaimers out there. What Dr. Pete and I are talking about today, please keep in mind, this is what he knows as of today. Things are changing not only daily, but by the hour, in particular for physicians on the front line, so please keep that in mind. And please know what he's talking about today is really kind of general medical guidelines and general medical updates. If you have questions specific to your medical condition, we would advise you to reach out to your primary care clinician. So with that being said, I would like to introduce Dr. Pete Melchert.
Hi, I'm Peter Melchert, and I'm an internal medicine and pediatric hospitalist at Abbott Northwestern, Children's Hospitals of Minnesota, and Gillette Children's.
And what areas do you work in primarily, Pete?
Yeah, I work in the inpatient hospital wards at all three of those facilities, taking care of hospitalized patients.
Okay. So Dr. Pete does, for those who aren't familiar with what a hospitalist does, Dr. Pete really is in charge of seeing almost every patient that comes in and has a need from, say, what a primary care doctor or a critical care doctor might offer. Dr. Pete is there to really serve all the patients that are there. So his job is big and massive, and he's seen a lot of everything right now.
I think of myself as a general contractor in the hospital.
Yeah, it's a good way to say
it. Yeah, and so I know a lot about how the body works and about different disease states. But if we need a specialist, then I coordinate bringing in a plumber or an electrician or a painter or whoever we need to help take care of you and fix up to go back home.
You know, you're a general contractor, I would definitely call. So that's good to know. That's great to know. And how, you know, Dr. Pete, I'll preface this. I was thinking about connecting with you today. And the last time you and I saw one another was at a lunch meeting just about a year ago.
Right.
And if you recall, I was on day 5 of a 5-day fast. And I was sitting there watching you and Eric eat lunch. And I had my continuous glucose monitor on. And if you've ever wondered if insulin starts to secrete from the pancreas with the sight or smell of food, I mean, I was like tanking. My blood sugars were going down. And I was trying so hard to stay focused on our conversation. And then at one point I showed you my CGM and you were ready to come at me with glucagon or, you know, a glass of orange juice. And I'm like, nope, I got to stay with this. I got to stay with the plan. And I barely made it through that lunch, I got to tell you. So I promise I'm a little bit more aware and alert today than I might have been a year ago during our last.
And you have stable glucose levels right now?
I have stable glucose levels.
Good.
I had some breakfast, I had a little coffee, so I'm good. I'm with you today. No worries about glucagon. But with that being said, Dr. Pete, I want to tap into your wisdom and kind of get a view of what you're seeing and feeling in the hospitals today.
Yeah, right now, the numbers of inpatients in the hospital are lower than usual.
Okay.
At the moment, and we expect that to be temporary.
Yeah.
Just recently, all elective cases were canceled.
Sure.
So that significantly reduced the inpatient burden on our hospitals. So that people that are there right now are because they're sick and need the support of what a hospital can provide.
Yeah.
So this was all done in anticipation of the coming flood of patients that may happen in the next 1, 2, 3, 4, 5 weeks.
Okay.
And also in an effort to conserve these precious PPEs that you've heard about on the news, the personal protective equipment. even in the course of routine patient care, we use a certain amount of those PPEs. And so we want to conserve as much of that supply as possible.
Yeah, yeah. Which makes perfect sense because, you know, I've heard different analogies of healthcare workers, you know, are like soldiers going into war without guns if they don't have their PPEs. So we really have to preserve them for you because you don't get to retreat back to your home like we do, you know, to do the social distancing and the social isolation. You are going right into the thick of it. And with you floating throughout the entire hospital, I mean, you're taking care of patients who've had, say, you know, massive heart attacks, strokes, you know, all kinds of different illnesses, and the COVID-19 patients. So
That's
you
right.
need to protect all the patients you have to see and you. So I'm glad to hear that the census is down. And can you maybe explain to people, you know, when you say all elective surgeries are canceled, like what does that mean? What is an elective surgery?
So let's say, for example, you've been working with your orthopedic surgeon over the last several months to get prepared for your hip or knee replacement. That's considered an elective surgery. It can be scheduled at a time or a date that's convenient for you and for your surgeon and for the hospital. And right now, none of those three are aligning very well. So those types of procedures are being put on the back burner to be taken care of later. So we're expecting in the few weeks here, as the numbers of infections increase and the numbers of people who are becoming ill with the infection increases, we're going to be pretty busy. And then as that declines, there's going to be a huge backlog of all the elective cases that need to be taken care of. So the whole rest of the year is going to be
busy. Yeah, for different reasons. But yeah, that's a great point to make. I didn't think about that with all the elective surgeries that eventually we'll have to get back on the schedule.
That's right.
That will make for a busy time for the hospital. Yeah.
Another thing that we're doing to plan right now is we're starting to diversify the hospital into areas that are going to be COVID treatment and COVID investigation departments. So we'll have one particular unit that used to take care of a variety of patients. Now it's just going to have patients who we suspect have COVID or those that we know definitively have COVID. And that will help us cohort patients to reduce transmitting it throughout the hospital. But also we can conserve the PPE by focusing it in just one area.
Yeah, absolutely. Which is critical because you have to put on a new PPE every time you see a COVID-19 patient, every time you go in and out of the room, every time a nurse goes in and out of the room. You have to redress and dress again.
In part, the guidelines change almost every hour. Certainly each day in the last 2 weeks, there's been a modification to the PPE recommendations. At the moment, if you're seeing consecutive COVID patients, you can keep your mask on as long as you had a face shield over the mask. And it looks like it's a clear, long white face shield. It looks like I'm welding.
Yeah, I've seen them. Yeah.
And so in between patients, I wipe off the front of that mask, of the face shield rather. I can keep my mask on underneath and then go to the next patient room. But I do need to change the gloves and the gown in between. And so what we're trying to do, another reason for cohorting all the COVID patients in one unit, is that you can see many of them consecutively and at least conserve the face shield use and the mask use.
Yeah. Okay, that's good. I mean,
but tomorrow that could change.
That could change. I know, it's so tricky. I've heard that from a few colleagues, and it's hard. I mean, and that's hard for you guys because you're like, well, then is what I did yesterday not good enough? Was I not protected yesterday? If it's changing today, but I know everyone's doing the best they can with the information that we're getting, and with the supplies. I mean, do you have the supplies you need for PPEs right now, let's say?
Another thing I was going to add to that is even the 3 different health systems I work at, all 3 of them are following slightly different guidelines and practices. Yep, and it's really important, I think, that there's uniformity so that we do this properly, we do it safely, and that all providers in the care spectrum are seeing us doing the same practices. I think if nurses or housekeepers who are also entering these danger zones see us all doing it different ways, there can be fear in well, wait a minute, you're not doing what I'm doing, or I'm doing something different than you're doing. Am I at risk?
Sure.
So uniformity of practice in this, I think, is critically important.
And how are the healthcare systems, at least in the Twin Cities, talking to try and make that happen?
Yep. That's happening to a large extent. There are management teams that are heading up the process through each hospital system.
Okay.
And they definitely talk to each other. We're all trying to learn from each other.
Right.
I think the question you'd asked just prior to this was, do we feel like we have enough?
Yeah.
And I would say most of us fear the future for the supply.
Mm-hmm.
At our current use rates, we have, I think, with surgical gowns, the type of ear loop gowns that are disposable, or those that tie right behind your head.
Right.
We have about a week supply of those at our current rate. And the same for gowns. I think it's like between 7 to 10 days of supplies for those.
Okay.
Yeah. And so now the respirators, the respirator is the word that's used for the N95 mask that you've heard of on the news.
Mm-hmm.
That's a more robust mask that can filter out much smaller particles.
Mm-hmm.
We use that for what's called airborne precautions versus droplet precautions. Those are two very different things. And airborne precautions means that the particles, the infectious particles, can last and float in the air for hours and hours on end. There's infections that we know that do that routinely. Tuberculosis, measles is a great example of that.
Mm-hmm.
Now, influenza, RSV, which is an infection that primarily affects infants at this time of the year, and COVID is primarily a droplet spread infection, which means snot bubbles and floating into the air that will last for a moment and then drop to the ground.
Okay.
However, there's a concern with COVID that certain procedures we do in the hospital, such as nebulized albuterol or CPAP or BiPAP masks, those may potentially aerosolize the viral particles and make them last in the environment much longer. So when we're doing procedures like that, that's when we need to wear these N95 masks.
Okay.
Our supply of the N95 masks was we were concerned about that volume of the supply.
Yeah.
Until just recently, when the federal government released some of the regulations on these types of masks. So these masks have broad applications. They're used not only in medicine, but they're also used in manufacturing, construction. So the federal government permitted use of the types, and it's similar to N95, it's a cousin to it, that previously was only able to be used in construction and manufacturing, now can be used for medical purposes. So that significantly increased our supply. And last, when we took our hospital group talked about this yesterday, we think we have more than 50 days supply, if I remember right, more than 50 day supplies of the N95s. And our plan with N95s is to reuse them. As long as we have the face shield over, we can clean in front of the face shield, we can go from patient to patient reusing those.
With the same N95 mask. Well, and that's, a critical point to make, because, looking at supply and demand and what's the capacity to get more as we start to see the peak of this year. And too, for people to recognize that you don't just need, you need them for the COVID-19 patients, but you still see TB patients, you still see patients, kiddos with RSV. So there's other things that they're still needed for. And I don't know if this is accurate. You could say, please correct me, but I even heard too, when they're intubating someone now, in particular someone with COVID-19, they're trying to pull out the healthcare staff out of the room to avoid exposure and save N95 masks. Is that accurate?
Exactly.
Okay. So when someone is extubated, it's called, meaning they had a breathing tube in and they have to pull it out or put it in. They're down to one, I think, anesthesiologist or respiratory therapist or nurse in the room, because that's a time when healthcare workers are likely to be exposed to the droplets.
Exactly.
So,
and then we find cohort patients who we know are going to require aerosolizing type procedures, meaning nebulizers, BiPAP or CPAP. we try to make sure that they're in a negative flow room.
Okay, okay. Which is what you would do for TB patients too.
Exactly.
And can you explain the negative flow room to the average person? What does that mean?
Yeah, it just means that there's vents in the ceiling that suck the air upwards so that it doesn't linger and flow out of the room into the hallways.
Okay, okay. And can they, with kind of the mock setups or the quick setups, I shouldn't say mock, but kind of the new established COVID units, will
Yes.
those have negative airflow rooms too?
Exactly. Yep,
Okay.
the entire units have been modified to be negative flow.
Wow, that's some fast work on everyone's part. That's impressive. Yep. Really impressive.
Yeah, and that brings about a really important, I think, remark here, that there are accolades going out in the media to healthcare providers who are on the front line, but it's an enormous community in the hospital of people that are working. Yeah. Doctors, nurses, respiratory therapists are critical in this time. Pharmacists, janitors, and housekeeping staff who are securing the safety and the cleanliness of our environment. Yeah. Security personnel. So all these people are coming in and out of the hospital and putting themselves and their families at risk, and all of them, we owe them, all of them, a debt of gratitude.
Thank you for mentioning that, because in some of the private Facebook COVID-19 medical groups I'm in, I hear that from different people. We say doctors and nurses a lot, but there's so many people in between that are making this all happen and providing care, and all of them deserve accolades. And thank you for bringing that to light, because I think it's important for people to recognize this is taking a tribe of healthcare professionals inside the walls to care for everyone. So in all of this, if you can see anybody who's, working overtime to give in any way, shape, or form right now, just recognize them. A simple thank you goes a long way. And Pete, I hope people hear what you just said, because it's really important that all of those individuals are being honored and recognized for their part. So thank you for that. So in following the trends of the illness, what we're all seeing and hearing is how much of an impact it's having on our lungs and our airway. Right. And why is this virus doing that more than maybe others?
Okay, great question. So one of the portals of entry of the virus into our system is via surface markers or receptors on the cells in our lungs. And we believe it's a receptor called the ACE2 receptor, angiotensin converting enzyme 2 receptor. And that's the method by which the virus is able to gain entry to our cells. Okay. Inhaling these droplets into your lungs then creates the mechanism by which the viral particles can enter your system. So you had asked about the mechanism by which COVID causes injury to the lungs. And so the patients who become critically ill with COVID develop a syndrome called ARDS, acute respiratory distress syndrome, or ARDS. What this looks like on a slide, if we were to take a biopsy of your lung, is called diffuse alveolar damage. Diffuse meaning widespread, alveolar meaning injury to the tiny air sacs that help you exchange oxygen between the environment and your bloodstream. And that happens in a widespread fashion throughout your lungs. Well, how does the virus do that? So as you inhale droplets that carry the viral particles, the virus has to get into your cells, and it does that by what we believe to be a receptor in our cells called the angiotensin converting enzyme 2 receptor. Okay. And so as the virus enters our cells, each of our cells is almost like your own body. Your body has many organs inside it. Well, each cell, the billions of cells in your body, have their own teeny tiny organs inside called organelles. And these organelles end up fusing with the surface of the membrane of your cell to bring the viral particle inside. And then the virus can replicate and cause damage to that cell. And when the alveolar cells in your body, let me back up. Your alveoli are very thin-walled. They're very thin-walled, and they need to be thin-walled so that gases can exchange across that membrane. Mm. And so it's a very thin, fragile membrane. And when the virus infects those cells and damages those cells, it's very hard to exchange gases. Mm. And I think about this like a tree, a tree that's upside down. So your body, your lungs are like a tree. You have a main trunk, your windpipe, and then it branches into each lung. And at the very end of each branch are many leaves, or your alveoli, that help you exchange gas. In the winter, all those leaves fall off, and so the tree can't get any energy anymore. When your alveoli are shed and are damaged or fall off, you can't breathe. And that's when patients become critically ill and require life supports with ventilator and other therapies.
Okay.
So I also think about the injury to the alveoli as an inflammatory process. So the virus infects the cells that line your airways and damages them. But when you, for example, hit your thumb with a hammer and your thumb becomes swollen and red and painful, that's inflammation. That's an inflammatory injury. And the same thing happens to your lungs in a widespread process. So these normally thin-walled alveoli that help you exchange oxygen in and carbon dioxide out are now thick and swollen like your damaged thumb. And it's hard to breathe. And patients become critically ill and can die.
That makes sense. Thank you for explaining that so wonderfully. Yeah, and in a way that I think most of us can kind of wrap our head around too, which is important. And can I ask a couple other questions that came up in my mind in regards to that? So from what I'm understanding, there seems to be more kind of like the intense flu-like symptoms in week 1, and the respiratory distress is coming in week 2. Is that because the virus sits in the cells in the upper airway initially and then move down? Or why is it that we're seeing kind of more of the respiratory distress a little farther along in the illness?
Not exactly sure. I think it's just taking more time for the infection to progress and to take a foothold.
Okay, maybe cause as much inflammation that it's creating respiratory issues.
I think so.
Not trying to get too much medical lingo going here, but what's interesting for those that are listening that are in the medical community is, from what I've seen and read so far, they're saying corticosteroids, which are a strong anti-inflammatory often used with respiratory disease, are actually being contraindicated or not recommended in the COVID-19 treatment unless there's an underlying disease like pulmonary COPD, some kind of other pulmonary disease. And so that's really, like, I'm trying to wrap my head around that. Why is it being contraindicated?
Yeah, I don't think we understand, but what it's been shown in China was that patients did poorly or fared worse when they were given steroids.
Right.
There's a very complex immune process taking place with these COVID infections. The ARDS that we talked about, with widespread damage to the air sacs in your lungs. But there's also an excessive inflammatory response mediated by cytokines, which are agents that turn on your immune system to fight the infection. But what appears to be happening is that it's turning on your immune system too much in an excessive way. And when that happens, your own body's immune system actually can be harmful. So some thoughts initially were that using steroids to calm that down be helpful, but that was not found to be the case. I don't think we understand why yet. But we do know that steroids should be avoided.
Yeah, which is so interesting. So what does that leave you with? Like, what kind of tools do you have?
That's where that's how I think chloroquine and hydroxychloroquine, these anti-malarial agents, started to become in use in China as a possible agent because they aren't as potent as steroids at modulating the immune system.
Right.
Chloroquine is used as an anti-malarial agent, but a derivative of it called hydroxychloroquine is used widely here in the United States to treat immune conditions such as lupus and other autoimmune conditions. It's not a very potent immune modulator, and so what we understand is that it may reduce some of the signaling by cytokines and limit some of that inflammatory process that's causing
Okay.
further illness or injury to the patient.
And
But we don't know any of this for sure.
right.
It's not something that people should be going out and trying to collect a supply for themselves.
Right.
There are studies ongoing to try to determine this. We don't know actually whether it may even be harmful, because the studies from China that suggested its use were anecdotal. And what an anecdotal study means is that somebody tried it in isolation. They didn't do it in a comparative fashion by taking one group of similar patients who didn't get it and another group of similar patients who did get it, and then comparing their results. So it's really important to not just take anecdotal evidence as scientific evidence.
Excellent point to make. And that's really hard to do, I would imagine, as a provider right now, because if you hear it working, you know, in light of a pandemic where, you know, it's like, how long do you wait until we can conduct clinical trials, but you also don't want to do more harm, because that has happened before with different things when we've put out a vaccine too quickly, or we put out a medication too quickly, and then we all of a sudden realize we've just created a bigger problem.
Yeah,
and
exactly.
so there is this fine line of moving it quickly but doing it safely. And you know, I heard another doc saying, you know, because now there's kind of, as the anti-malaria drug information is getting out to the public, people are looking for it and seeking it.
Yeah.
But I also heard someone say, you know, there's danger in that because of its impact on the heart, and it can create heart arrhythmias for people. So it takes a physician or a clinician to manage a prescription or use of anti-malaria medications to make sure you don't have other risk factors in taking that medication that might become worse if you do.
Exactly.
So it's not, you know, just like you're grabbing a Tylenol off the shelf. And to your point, right now it's anecdotal. It's being studied. We're learning about it. It certainly has potential. One other med I've heard about is azithromycin in combination with anti-malaria drugs. Have you heard that?
Yeah. Yep. And the reason for that is that azithromycin and other macrolide type antibiotics are felt to have very mild anti-inflammatory properties. Yeah. So there are some patients who have chronic recurrent pneumonias or respiratory infections, and under the care of their specialist, take prophylactic azithromycin to prevent flares of infections. And we've been doing that for a while now.
Yeah.
So I think it was a little surprised that people were going to consider trying that for COVID.
Thank you for explaining that, because, you know, as a triage nurse, it's out, you know, in past working triage of any kind as a nurse, you know, you're so used to people, you have a virus, we can't treat it with antibiotics. I know you want one, it doesn't work. And so for people, now that we're talking about a virus, but we're talking about an antibiotic potential combination treatment, you know, I was just trying to wrap my head around how those are intersecting and how that's making sense. So thank you for that. That's really helpful. Can I ask what you're seeing between, say, like Abbott versus Children's Hospital? You know, you're crossing between two very different populations, and what's the difference in what you're seeing in the populations?
Yeah, we're seeing very low incidence of COVID, thankfully, in children. So influenza follows a U-shaped curve, meaning that there is morbidity and mortality at very young ages, and then again comes back up again at advanced ages, a U-shaped curve. This seems to have a J-shaped curve, meaning a little bit maybe if for young infants, and then as you advance in age, a much more significant burden of morbidity and mortality. So as far as the tests that we've done so far at Children's, the numbers have been very, very low.
Okay. And those that have been positive, are they doing okay? Are the pediatrics who are testing positive, I mean, are they quite sick?
None of them are in the hospital. None of that I know of are in the hospital, and we know of about 5 kids that have tested positive.
Okay.
And one that was like, I think 6 months, and then the rest were teenagers.
Okay, so that's
but none of them that I know of are in the hospital.
That's very reassuring, because the difference, the variability between COVID-19 and influenza is influenza hits the pediatric population usually quite hard. So thankfully, COVID has at least thus far been pediatric sparing. So that's a big relief. And I'm happy to hear that's what you're seeing in the inpatient side of things too.
In both campuses at the adult and pediatric facilities, we have a whole backlog of tests that are still pending.
Okay.
So that's a problem on both campuses, is the pace and the volume with which we can test.
Sure.
It's been a problem since the beginning of this whole crisis.
Yeah.
You know that recently private industry was brought into the realm of testing. And that expanded the numbers of tests, but there still is a large backlog. So my hospital, formerly all of our tests at Abbott Northwestern and from Children's were going to the Minnesota Department of Health and being run at the Minnesota Department of Health. The results were taking about on average about 72 hours to get the test back. And since it's moved to private companies, we've been able to do more tests, but the backlog actually seems to have increased to now it's up to even 5 days that we're waiting to get results. Yeah.
That's a lot.
So we have a large number of patients sitting in the hospital who are sick that don't know the results yet. And many of those people are getting better and going home before they even know the result.
Well, and I guess that's good to hear, because I think the message in that is really at this time, whether if you present with symptoms of COVID-19, you're going to be treated in the same way that you would even if you get the confirmation that you have COVID-19, the treatment, supportive treatment in the same way. So you just have to kind of take anyone with those symptoms. Do you rule out the flu first, like influenza first?
We used to do flu first, and then if it was negative, we would then test for COVID. But we were finding that we were running through our test swabs too quickly, and we were worried about running out of that supply. So we're doing them both at the same time now. And initially, we were doing flu first because there was felt to be a low incidence or unlikelihood of having both. But now we're not so sure about that. There's some evidence coming out that 5% or more of patients could have two viral infections going on at the same time. And so we think it's important to really know if you present with respiratory symptoms that you'll be tested.
Yeah. I kind of wonder, because really isn't now kind of the peak of the influenza season too?
It's going to be starting to be tapering down, but we're kind of in the midst of it. This year it actually hit us much earlier than it typically does. But in total, my understanding is that the hospitalization numbers is about the same as it was previous.
Well, it may be good that it's hit early and tapering sooner for this season, given COVID is now there.
We still are seeing influenza cases at this time.
And have you been able to, I heard a little bit about Mayo having this more rapid test. Is that accessible to you right now? Has that been distributed?
Nope,
we don't have approved?
We don't have that yet.
Don't have it yet. Okay. All right. So hopefully.
But it would be great to have a test similar to influenza and RSV right now, where I can get a result in less than an hour and really be operating in real time. I think of it like right now is tax season. And so I think about an accountant's office. Let's say, for example, they need 100 calculators to do their work, to add up and run the numbers. But you only have 5 calculators. And then when you add up the numbers, you have to wait 3 to 5 days to get the result. That's where we are right now.
That's where you are. Yeah. That's so hard. Diagnostics are such a big part of what you do. And it's really hard, I think, for people to just not know, to even have mild symptoms and be like, do I have it? Do I not? And in the hospital, for you as clinicians trying to figure out how to treat, I mean, even though right now the tools you have are kind of relatively the same either way, but just that not knowing for that length of time is hard for everyone. Yeah. So hopefully Mayo and whatever brilliant minds are working on that, thank you, and move quick for everyone's sake.
Right.
So Dr. Pete, if you don't mind, I'm going to kind of take us from local Twin Cities area to across the globe, because I want to share with everybody that Dr. Pete is not only going between 3 hospitals in the Twin Cities and caring for both the adult and pediatric population. And I think are you still working 7 days on and 7 days off? Is that your schedule still? And then when he's on his 7 days off, clearly he has a young family, but he also has a passion and a deep purpose in serving those in other countries and providing medical care in other countries where it's lacking. And he has done incredible work in many countries, Africa being one of them, treating conditions and helping train other medical professions in those countries to treat conditions that are really devastating overseas. And, you know, when I think about Africa right now, I don't know how you socially distance and isolate there in those villages and tribes. And I don't know, they don't have access to healthcare. And, you know, I heard these statistics just to put a little perspective on it. And then I want you to share what you do overseas, the organization you do it with. And I don't even, you know, what's happening in Africa, but for those listening, 71% of the world's population lives on less than $10 a day. Half the world lives on less than $5.50 per day. Nearly 152 million Nigerians live on less than $2 per day. So what we're facing in our country is very scary, but we have, at least on the healthcare side and on the psychosocial support side, we have resources. They're not perfect, but we have a lot of them. There are people in other countries like Africa who have very few resources. So Dr. Pete, with that, can you tell everyone what you do overseas and then how they're being impacted by COVID-19 in third world impoverished countries?
Yeah, thank you for that, Krista. So I'm the medical director of a nonprofit organization called Medical Simulation International, and we develop novel computer-based simulation training tools to teach physicians in low-resource nations how to do specific medical procedures. And so I think of it as distance learning, which right now we're all getting a crash course in how to have distance meetings, distance interviews, and distance learning. All the school systems are preparing for distance learning. And so, yeah, that's what I do. A lot of that work is on hold right now with travel restrictions and work restrictions abroad. And yeah, you raise a very important point about the lack of resources. We're concerned about running out of enough protective equipment and ventilators and sanitizing supplies. But many of the low resource nations that we're talking about don't have adequate supplies now just for baseline needs, much less for when a crisis hits of this nature. So the close proximity of people in living environments in low resource areas, the lack of healthcare facilities, the lack of protective equipment and sanitizing supplies is great concern of what could happen in Africa, for instance. Counter to that, though, however, is that due to the low resources, there is a smaller population of people with advanced age and with complex medical conditions.
Sure.
So here in the United States, we talk about how children are less affected, but many of us in pediatrics are very concerned about the large population of pediatric patients we have with complex disease, who live on ventilators at home, who are survivors of cancer, who have complex congenital conditions, and live on the margin right now, but with the supports we have, they can survive and thrive.
Sure.
Many of these children don't survive in low resource areas, and many people with complex conditions don't survive as adults, and certainly not into the advanced ages like 70s and 80s, where we're concerned about the highest mortality. So if that makes some sense, the J-curve that affects the advanced ages with morbidity and mortality doesn't exist to that extent in low resource areas.
You know, and I appreciate that point of view because that makes sense. I mean, this is kind of somewhat on the tail end of what you think of in the J-curve of lifespan and longevity, because really their issues are so far ahead of what we're seeing here with COVID-19 that it decreases the risk of COVID-19 for equally as challenging circumstances, but, you know, different circumstances. And I think that's a great point. And that's why, you know, I've heard different reports saying they're concerned that the US could be hit harder than any other country because we do have so many chronic disease is prevalent in our population. We do have such a large pool of elderly people, maybe not as much as say Italy, but those living, even younger ages have really significant chronic disease in our country right now, and our resources are allowing them to have a quality of life that doesn't exist in every other country though. So, so do you worry about those peds patients, who are on ventilators and have really severe asthma and really, CF, cystic fibrosis, or, are they all of a sudden now in the same high risk category as say an elderly individual, or we just don't know?
I don't think we know. I don't think we know, but I think it's fair to say and to caution everybody that if you have a chronic medical condition at any age, that would confer a greater risk to you.
Yeah. Okay. That makes sense. So we just have to protect those that have other chronic diseases and comorbidities, and that's why we're all socially isolating and distancing. It's primarily for those individuals, and you, so that you don't get 200 people one night showing up who are all really critically ill, and there's only so many of you. There's only so many respiratory therapists. There's only so many PPEs, so many RTs and X-ray techs, and we have to protect them all.
That is what we fear. That's exactly what we fear. Is does it spike too fast, too high, soon, or can we spread it out over time and spread the curve into the summer so that we can manage it?
Yeah. And I think we're starting to all wrap our head around a little bit that this isn't a sprint. We don't want it to be a sprint. It might look a little bit more like a marathon.
Right.
And I think just wrapping our heads around what that all means, we're still all figuring out how to do that. But we have to do that because we can't have that peak like they've seen in Italy and Spain, where it's just devastating with that mass influx of really critically ill patients. So Dr. Pete, I kind of have been wrapping up interviews with the question of how are you taking care of you right now and your family, and how do we help you stay well in all of this?
Yeah, I think the message that my colleagues and I would like to share with the community is we're going to work for you, so you stay home for us. By you staying home, you can limit the spread and help save the community and the healthcare systems from becoming overrun. So we're going to go to work, we're going to do what we do and do it to the best of our ability, and you stay home for us.
Powerful message and a really good reminder. And I hope people hear that. We've had other interviews where we talk about those symptoms to stay home and symptoms to go, but really take that to heart, because we have to preserve our resources. And if you are otherwise faring well at home, stay home. And if as much as you can isolate right now, we all have to do our part and protect you and protect those at high risk. So thank you for reminding us of that. We have to keep that front and center so that we don't end up being the next Italy. So thank you for that. And are there any other messages that you want to share in all of this that you think are important for people to hear?
Well, you asked what my family, what we're doing to survive and make our way through this is developing routine, especially with kids at home. That routine is so important. They're used to the school routine and the activities and the movement and the learning, and trying to keep that going and developing a regular routine of waking up at a right time, making your bed every day just like you do, cleaning, showering, dressing up, and spending a certain amount of time on some academic activities and some on some relaxation and some on some physical activity, and making that a regular routine every day, I think is really important.
Incredibly important, and not always easy to do with kids at home and parents trying to work. But that psychosocial component of health translates into your physical health. And so we have to focus on what we can do to stay mentally and physically strong through all of this. And that routine and those healthy lifestyle habits are critical in that. and you have a young son, and, you know, I'm sure you and your wife are trying to figure out what's this new normal look like. But I just woke up this morning thinking about that. I'm like, okay, my kids think it's still spring break. And I'm like, spring break does have an end, even when we're staycationing in Minnesota, because, you know, we have to develop some new normalcy to life. Yeah, so an important message. So Dr. Pete, you are one incredible human clinician provider, and you have graciously given much of your wisdom and your time, and I know you have many other things that you need to focus on for the rest of your day, and I just want to say a deep and heartfelt thank you for what you're doing, what your colleagues are doing. Thank you for saving all those lives, and thank you for doing and giving to all of those who walk through your doors. You're an appreciated person, so thank you.
It's a privilege. Thank you.